I'm Emily Robinson, PGY3 Emergency Medicine Resident at University of Texas. Today I'm presenting an abstract titled Prehospital Ketamine Administration for Pain Control Does Not Prolong Emergency Department Length of Stay. And I have no conflicts of interest to disclose. Some background. Recently, low-dose ketamine has emerged as a potential pre-hospital analgesic as an alternative to opioids. Ketamine's been found to be as efficacious as morphine and fentanyl for pain control. However, these three medications have very different side effect profiles, specifically ketamine, which carries the risk of disorientation, agitation, and excessive sedation. Due to these side effects, there's been concern that pre-hospital ketamine administration results in longer emergency department length of stay. However, this has never been formally evaluated. The purpose of this study is to compare ED length of stay among patients receiving ketamine, morphine, and fentanyl in the pre-hospital setting, specifically for pain control. This was a retrospective observational study using the data from electronic records with linked ED length of stay data collected in the year 2018. The data was obtained from a de-identified research database maintained by ESO Incorporated, which is a provider of pre-hospital electronic health record software that compiles events, demographics, and clinical data for over 1,200 EMS agencies in the United States. A subset of these agencies participate in what's called the ESO Health Data Exchange, which allows linkage of pre-hospital records with hospital data. Our analysis was limited to adults who were involved in an EMS 911 scene response who received morphine, fentanyl, or ketamine, who had documented pain scales of equal or greater than 4, had an associated primary or secondary impression that was related to a painful condition. Subjects were excluded if any combination of the three medications were given, and since ketamine can be used as an induction agent for RSI, we attempted to exclude those encounters by excluding patients who had a diagnosis listed such as altered mental status, GCS of less than 14, head injury, multi-system trauma, or respiratory complaints. Additionally, since ketamine can be used as a sedative, we excluded patients with mental health or behavioral diagnosis such as psychosis, hallucinations, or substance-related complaints. This is how we accrued our subjects. We started with over 7.5 million encounters, and once we excluded those without length of stay data and those to whom no pain medications were given, we applied our inclusion and exclusion criteria and ultimately resulted in 9,548 subjects. 119 of them received ketamine, 1,359 received morphine, and 8,070 received fentanyl. Our primary analysis was a comparison of ED length of stay in hours among the three medication groups, and this was reported using a Kruskal-Wallis test to evaluate ED length of stay overall, with a subsequent pairwise between medication comparison that was done with a Wilcoxon rank sum test and Bonferroni corrected alpha values. We also compared length of stay among all patients receiving pre-hospital ketamine, morphine, or fentanyl, regardless of the indication, and this comparison was performed using the same methods as our primary analysis. The overall median length of stay for all medications was 3.8 hours. The length of stay data was statistically different when using the Kruskal-Wallis test to compare all three sets of data for overall comparison. And as you can see, the total length of stay for ketamine was 3.5 hours, 4.0 hours for fentanyl, and 3.7 hours for morphine. While there was a statistical difference when comparing overall data, in the subsequent pairwise comparison for between group differences, there was actually no statistical difference, with the exception of comparing morphine to fentanyl. Therefore, there was no statistical difference between the length of stay when comparing ketamine to morphine and ketamine to fentanyl. It's also important to note that even though there was a difference between morphine and fentanyl, it's of questionable clinical importance as it was only about 18 minutes. However, when we included all adult patients involved in a 911 scene response who received any of the three medications, regardless of the indication or any of our inclusion or exclusion criteria, the length of stay was actually statistically different. In this analysis, ketamine actually had the longest median length of stay, which was 5.5 hours, and fentanyl had the shortest with a length of 3.8 hours. So despite anecdotal belief, this study actually demonstrated that ED length of stay does not meaningfully differ for patients who receive pre-hospital ketamine, morphine, or fentanyl when administered for the purpose of pain control. Contrary to anecdotal expectations, this analysis actually showed that patients who received ketamine had the shortest length of stay, approximately 12 minutes shorter than fentanyl and 30 minutes shorter than morphine. However, these differences are not statistically significant or likely to be clinically meaningful, as it's estimated that in general, the minimal clinically important difference for ED length of stay is somewhere between 30 minutes and 1 hour. On the contrary, when we included all patients who received these 3 medications, regardless of the indication or our exclusion criteria, the ED length of stay was actually much longer for patients who received ketamine. And this is likely at least partially responsible for the anecdotal association between ketamine and the prolongation of ED length of stay. This study was limited by its retrospective nature and by the limitations of the ESO database, as the majority of events recorded in the ESO database actually did not have ED length of stay data available. Additionally, the number of patient encounters that included ketamine administration was markedly smaller than morphine and fentanyl, and this was actually expected and most likely secondary to the fact that only about 1/3 of the US EMS agencies actually have protocols that allow ketamine administration. Lastly, the ESO database, there's not direct record of indication for medication administration. Therefore, we presume that patients who had painful conditions linked to their ESO encounter and who received the medication in question were actually receiving those medications for the purpose of pain control. Therefore, we concluded that there is no meaningful or clinically significant difference in ED length of stay for patients who receive pre-hospital ketamine, fentanyl, or morphine specifically for pain. Thanks, and please contact me at the email listed below if you have any questions.